respected chairpersons of the session, and in front of me, the founder of interventional cardiology in Bangladesh, Professor Emeritus, Professor Sufiya Rahman, and senior most professor, Professor Hasina Banu, and one of the renowned interventionalists, Professor Fazilatun Malik, and all other faculties and delegates. Assalamu alaikum. I like to tell about the intervention in last 40 years all over the world. If we see from 77 to till date. And 1977, here we know the first human case in coronary balloon angioplasty, a young German angiologist, Andreas Gruenzig, who started with plain angioplasty, plain old balloon angioplasty. And you see on the left panel, Andreas Gruenzig dilated proximal LED lesion through a catheter, performing first human PTCA. And this is the result after in 2000 case from 1977 to a lower panel 2014. And this is the result of that plain balloon angioplasty. And later on, we come to 1981. In 1981, John Simpson created a new catheter system for coronary angioplasty with an independently steerable guide wire. And 1986, intervention of monorail catheter. These people, that is Tassilo Bunjil, Germany, invented the rapid exchange catheter known as monorail catheter. Implantation of the first coronary wall stent in 1986. March 1986, first coronary wall stent was implanted, and first bailout situation by wall stent in 1986. And in 87, these devices were discovered and saw the introduction of various catheter devices such as laser, directional and rotational atherectomy, cutting balloon, brachytherapy, transmyocardial, laser myocardial, revascularization. And regarding limitation of this plastic, as we know, there is the important limitation is the restenosis, and approximately 30% restenosis are with bare metal stent, and that is why in Julio Palmaz first invented bare metal stent. First invented bare metal stent, Julio Palmaz, and this was implanted in 1989. And then 1993, first transmyocardial coronary, first transradial coronary intervention started. And this is the implantation of the first drug-eluting Palmaz-Schatz Cypher stent, and pre-post after 10 years, you see on the left panel, pre-post, second panel post, and 10 years after the result of that drug-eluting Palmaz-Schatz Cypher stent first implanted. And in 1996, you see, came to the concept of dual antiplatelet therapy, how to reduce the complication of intervention. And in 2003, approximately, there are many studies came for primary PCI, which is going on, and nowadays it is class 1 indication. And then come the revolution of different types of stent. There are fourth revolution now, and first revolution with this balloon angioplasty, then bare metal stent, then coronary drug-eluting stent, generation 1, generation 2, and then bioabsorbable scaffold. And metallic stent and DES, as we have told that metallic stent without drug-eluting stent, there is more chances of restenosis, and that is why drug-eluting stent has come. And stent platform, there are various stent platforms out of which to reduce the stent start thickness while maintaining the radio opacity, and strength is the goal. And traditional 316 stainless steel is replaced by cobalt chromium and then platinum chromium, and the start thickness also reduced from 140 micrometer to nowadays 64. And these are the different stent designs. Starting on the left panel, this is Cypher Select, and on the right panel, Omega, that is 81, and nowadays that is Orsiro, that is 64 micrometer. And starts and lower coating thickness, and this start thickness is one of the important issue, and second one is coating. And regarding this evolution of the stent architecture, and we know there are different changes of the architecture. Addition of connectors on proximal two segments, it was added, and proximal end more robust to provide increased axial strength. And regarding polymer, then comes to the polymer, and polymer, durable polymer, then bioabsorbable polymer, then comes to the polymer free stent. And this comparison of a safe polymer, it mimics the body's chemistry and extended drug elution compatible with stent delivery, and these are the different types of BioLinks polymer, non-inflammatory, rapid and functional endothelial healing. And abluminal versus conformal polymer, if we give abluminal polymer, you see the endothelialization will be earlier rather than conformal polymer. And comparison of first generation with second generation drug-eluting stent, here shows the use of second generation drug-eluting stent is associated with better clinical outcomes compared to the first generation DES in terms of MI and stent thrombosis. And dedicated bifurcation stents, then come to the different types of dedicated bifurcation stents, though the dedicated bifurcation stent did not get market as because there are some difficulty in implanting this dedicated bifurcation stents. Then comes to the drug-coated balloon. Then drug-coated balloon, as because this drug-coated balloon, we can leave the vessel without any foreign body. So it is helpful in some cases, but not in most of the cases. And then comes to the physiological assessment of coronary angioplasty, and we know there is FFR, and we do this FFR for different reasons, and when evidence of ischemia is not available, FFR or IFR are recommended to assess the hemodynamic relevance of intermediate grade stenosis. This is class 1 indication. And why FFR? Angiography is not always enough. FFR is the only matched index with objective ischemia even in the left main disease, and assessment of ischemia in left main and side branch intermediate LMCA disease with FFR greater than 0.75 to 0.80 can be safely deferred revascularization. And 2021 SCAI SCAI guidelines, they showed that class 1 indication in patients with angina or an angina equivalent, undocumented ischemia and angiographically intermediate stenosis, the use of fractional flow reserve or instantaneous wave free ratio is recommended as class 1 indication. And then comes to the intravascular imaging. You see in the coronary angiogram, we see the only luminography, and intravascular imaging, we see that in interior of the vessel. And IVUS, intravascular ultrasound, should be considered to assess the severity of unprotected left main lesion, class 2A indication. And IVUS should be considered to optimize treatment on unprotected left main lesion, that is also class 2A indication. In 2021 SCAI and SCAI guidelines for coronary revascularization, they also take it as class 2A indication. And why IVUS guided left main stenting? Is it necessary? Is it mandatory? Yes, it is necessary, but not mandatory. Lesion assessment, treat or not to treat, and assessment of lesion characteristics, selection of PCI technique, selection of appropriate device, procedural optimization, assessment of DES failures. And IVUS guidance, LM PCI optimization, and we know the relative criteria, have good apposition, stent expansion, stent symmetry, and absolute criteria when we use IVUS, that is more than 5 square millimeter at the ostium of the LCX, more than 6 square millimeter at the ostium of the LAD, more than 7 square millimeter at the polygon of confusion and confluence, and more than 8 square millimeter at the LMC. We want this, and that is why IVUS is essential. And IVUS guided LM PCI, it increases reduces the mortality in course of time. And integrated use of IVUS and FFR. Avoid unnecessary PCI, avoid unnecessary surgery, minimize MACE, as well as maximize clinical outcomes, save money and save lives. And here we have shown what I have told in the previous slide, that is MLA 4.5 to 6 consider physiological assessment. And then comes to the plaque modification. Plaque modification, there are several techniques for plaque modification, out of which scoring balloon, cutting balloon, and then atherectomy, rotational atherectomy, orbital atherectomy, excimer laser coronary angioplasty. This is rotational atherectomy system, rotablation system. Rotational atherectomy is an endovascular procedure to able atherosclerotic plaque by forward advancement of a rotating abrasive bar and rotablation technique developed by David Oath in early 1980s, but gradually it gets its importance and works on the principle of differential cutting and lesion preparation using rotational atherectomy prior to stent deployment in heavily calcified balloon undilatable lesion sometimes becomes essential. Coronary atherectomy recommendation, as you know, and what we expect in future that has already come to in Asia, already done, already going on in India, in Ahmedabad, Dr. Patel's Center. Robotic percutaneous coronary intervention is a novel approach to performing where operator can utilize remotely controlled technology to manipulate guide wires and catheter devices. And lack of radiation hazard, improve accuracy and successful in early trials. And process includes injection, further stem cell therapy, and this process includes injecting adult stem cells at the time that an angioplasty procedure is performed to stop the heart attack in progress, and these stem cells are taken from the heart patient's bone marrow and injected into the heart with the hope for outcome of generating new healthy heart tissue and improving long-term heart functioning. Though it does not gain the popularity, it is also in the field for a long time. And that is also in the currently in trial. Thank you for patience hearing.